Bismillahirrahmanirrahim. Good afternoon to all the participants who have joined us for this Policy Dialogue webinar series. I welcome you all to our today's Policy Dialogue webinar series, and our topic is nurse-led clinics. There's a strong evidence that nurse-led clinic positively impact healthcare delivery system, improve quality of care, and improve patients' outcome. We are very much honored by the presence of our distinguished speaker today, and I would like to share her brief intro with you all. Today we have with us Riaz Kauser Mardani. She is highly accomplished healthcare professional with an extensive background in nursing education, leadership, and nursing practice. Her academic journey include Diploma in General Nursing, BSc and MSc in Advanced Clinical Practice. With over 3 decades of experience, she has held different diverse roles at Aga Khan University Hospital in Karachi, contributing to ISO 9001 audits and showcasing a dedication to quality healthcare. Her leadership as an acute oncology lead nursing highlights its adaptability and commitment to professional efficiency and safety protocol. Her experience at Bishop's Wood Healthcare and prestigious institutions like Imperial College Healthcare Trust and Royal Hospital involve roles such as chemotherapy specialist nurse and breast specialist nurse. Notably, during the COVID-19 pandemic, she played a crucial role in establishing an acute oncology assessment unit at Mount Vernon Cancer Centre. Beyond clinical role, Riaz is actively engaged in teaching, clinical supervision, and mentorship, underscoring his commitment to education and staff development. Her comprehensive skill sets, leadership experience, and passion for patient care position him as an asset to healthcare, capable of navigating diverse environment and contributing significantly to healthcare excellence. Over to you, Riaz. You can start your presentation now.
So I'm Riaz. I'm working in acute oncology service at Mount Vernon. Good morning, good afternoon, good evening, whoever is logged in from other places. So I will show my objectives for today's presentation. So we will learn about what is acute oncology service and what are the requirements to work in acute oncology as a nurse practitioner. What is the role of cancer center, which is a stand-alone cancer center, what type of calls we receive by the triage line, what type of patients we review, and what is the role of ACP in acute oncology service. So if you look at the background of acute oncology service, it was identified the deficiencies in the management of cancer patients who were admitting with the complications. It could be related to the cancer or cancer treatment, and it was identified in 2008 by the National Confidential Inquiry into Patient Outcome and Death. It was noticed that so many patients were dying because they were not managed properly, and they were having maybe neutropenic sepsis. It was not picked up, and they had an inquiry which made them think there should be a separate service who look after these patients. So the lack of experience of the general medicine team, because what happens, the patient normally goes to A&E or to GP service, general practitioners, where they may lack the knowledge and experience of cancer treatments. So that's why it was identified that all the hospitals who have emergency department, they should have a dedicated acute oncology service. So the aim of the acute oncology service are admission avoidance, decrease hospital length of stay, avoid readmission rate, prevent 30 days mortality from anti-cancer treatment, avoid neutropenic sepsis-related deaths, management of metastatic spinal cord compression, improve patient experience, manage emergency presentation of new cancer as outpatient. Because what was happening that any patient who is unwell, they go to A&E and then they get admitted and they were not managed properly and the diagnosis were not done and the patient stayed in the hospital for maybe weeks and months. So it was identified that acute oncology can play a role, that they can identify this patient and this patient can have investigation as an outpatient, like they can have scan, they can have biopsies, and then the case can be discussed in MDT. And when the decision is made, then they can refer to the appropriate team for the management of the cancer. And it is also an important role of acute oncology to improve the communication with the wider team, just outside the boundaries. Like if we are in cancer center, we can provide help and support via communication through email or telephone to those healthcare professionals who are not oncology trained and they are looking after oncology patients. So the cancer center is where I'm working is a standalone cancer center. We only have outpatient department, chemotherapy department, where we give chemotherapy and immunotherapy, targeted therapy, supportive treatment, and radiotherapy. We don't have like ITU, high dependency unit or theaters in our cancer center. The chemotherapy department works from 8 to 8 and administers almost 50 to 60 patients chemotherapies in a day. Radiotherapy department works 8 till 6 and that provides radiotherapy to the wider catchment area because radiotherapy most of the hospital don't have. It's only the specialized areas they can give radiotherapy. That's why lots of patients from other hospitals, they come for radiotherapy in our clinic. We have an outpatient clinic where the patient get the diagnosis. When they have biopsy and DGH, then they refer to us via MDT, and then we give them the diagnosis, and then we discuss their planned treatment and their consent for the treatment, and they also come in between their treatment for review in an outpatient clinic. We have a scanner center where we do the staging scans, and if the patient need to have scan before starting the treatment, we do that as well. That works from 9 to 7. Pharmacy is limited as well. They provide chemotherapy and they take home medications to the patient, and they work from 9 to 7. We have a small inpatient ward where we provide inpatient chemotherapies for those patients who require long regimens, such as germ cell tumor patients, and we only admit those patients who need palliative support. Very occasionally, we admit any unwell patient on site. We have acute oncology assessment unit, which we established in 2020 during the COVID time, and it works between 8 and 8. And we review unwell patients, those who are in treatment, and we have a triage line, which is working 24 hours. So nurses hold the phone in AOS unit from 8 to 8. And after that period, the night nurses from the ward hold that 24 hours helpline. We bring patients from triage line for review between 8 and 4. And after that, if any patient is unwell on site, we can review them as well. At Cancer Center, we have 24 hours triage line. We use a Yukon telephone triage tool to assess patients. We have assessment unit. We have developed a performer to review patients in the unit. those who are unwell on treatment or unwell because of the cancer itself. And we have outreach service in cancer center where one of the ACP holds belief, and anybody unwell on site, we go and see them. For that, we have to have ALS course, which is advanced life support course. So this is a 24 hours triage performer. It has been developed by the UCONS, which is United Kingdom Oncology Nurses. This has all the information which we need to triage a patient. So which patient hospital belongs to, their information about their name, date of birth, telephone number, what type of cancer they have, who is the consultant looking after them, for male, female, and who is calling. Is it the patient themselves or somebody else calling for the patient? And then the reason for the call. And here we have to identify which treatment they are on. If they're on chemotherapy, immunotherapy, radiotherapy, any other treatment or supportive treatment, what is the regimen of the treatment? Are they on Folfos? Are they on EC? Are they on PAM? What treatment they are on? And is it a trial or not? And are they, when did they have their treatment? Within 7 days, 14 days, 28 days? And have they checked the temperature if they have fever? And if they have they taken any paracetamol? Are they still connected to any medication? Do they have any central line, PIC line or port? All this information we have to identify. And then we have to identify their symptoms, what symptoms they are having and what is their scoring. So we have this signal light system. If it is green, then we can just advise them on their symptoms. If they have yellow, we can still find out if they have any medication, they can use it or they can go to their GP. If there are 2 ambers, then it has to be counted as 1 red. Somebody is having fever on chemotherapy, it is all red. If somebody is having chest pain, it goes to red, because this patient need to be seen urgently. So any patient who has chest pain need to go to A&E department. Anybody who is having fever on SEC, we can bring them in our unit and we can see them. We don't want them to sit in the waiting area in A&E and then they get delayed. We find out if there is any medical history significant, they have any surgeries, if they have diabetes, high blood pressure, if they have any cardiac condition, what treatment they are on, we need to find out, and what action we have taken. We have to document it here. And the nurse will, any patient who has been advised on the phone, we have to follow them up. So nurse is right here, this patient needs follow-up, and then the nurse who is taking over will follow it up, maybe in few hours or maybe next day, depend on the situation. So on the triage line, on daily basis, we receive 25 to 30 calls, and the calls mainly related to fever. If they have mucositis, unable to eat and drink because of the pain in the mouth, they have shortness of breath, constipation, diarrhea, nausea, vomiting, swelling in the upper or lower extremities, query DVT, rash, maybe related to chemotherapy or immunotherapy, if they have too fatigue, chest pain, or bleeding. So if they are too unwell, we advise them to go to A&E. And if they are not able to go to A&E, we ask them to call 999. So ambulance come and assess them at home. And if they need to go to A&E, they will take them there, and they will have a communication with our 24-hour helpline. So we can provide them further information if they need to make a decision that this patient need to go to A&E. And these patients followed up. For the toxicity, there are 2 different triage guidelines we use. One is called UCONS toxicity guide, and the other is ASMO, which provides very clear guides that if this is the category, what is the next step, what you should be doing. And this is the website where you can go and look for these guidelines for the UCONs. This is updated in 2023. This is the assessment performer, which I developed when I started in this department. So before patient comes, we have some information because patient has been triaged already most of the time. So we know what type of cancer patient has, who is the consultant, what treatment they are on, when they had their treatment, and what is their presenting complaints. So when the patient comes, we take full detail, medical history, medication history, allergies. This is also very important to find out who is at home with the patient, whether the patient living alone, do they have transport to come. Also, we find out if they're still smoking or they drink, because these things are important when the patient is on cancer treatment. It's not safe to drink because the chemotherapy can affect on the liver as well as the alcohol. So this is important for the teaching point as well. This is the observation we do. If the patient is using high, like if their blood pressure is high or temperature is high, so we have a new score system which gives us indication that this patient's observation need to be monitored more frequently. So we start new scoring chart, which is a separate chart we start. If the patient observation are stable, then we repeat at some point again. So there's another option. So and here it says journal and skin and PP. So when you look at the patient, we have to identify how the patient looks, how their skin looks, if they have any rash, if they have any wound, any bleeding from anywhere, or PPE is the palmoplantar erythema, which is one of the side effects of the cancer treatment, which is called capecitabine. So it is very important to identify when the patient is on capecitabine, whether they're having this, because sometimes the patient doesn't mention. So it is very important to examine their palms and their soles. So to identify if they have sometime it has been missed because patient doesn't show it. Patient have blisters in the soles and they get missed. In the mouth, it is also very important to examine patient's mouth because they are very prone to get mucositis, and some patient because of that they don't eat and they lose weight, which is not good for this patient because their treatment is prescribed based on their weight. So it is important that they should maintain their weight. So examining their mouth, advising them on mouth washes, looking after their appetite, all these things are important when they are on chemotherapy. And we do the chest examination, listen, inspection, palpation, auscultation, all these things we do for the cardiac, respiratory system, cardiac system. We do, if there is need for neuro assessment, we do all the cranial nerves. And for MSCC, we check if the patient is mobile, how their gait is, upper and lower limbs power. It is very important to find out if they're incontinence or constipation or they are retaining urine. For MSCC, we also perform PR examination depending on the situation. And we check patient's calf and ankle to identify if they have any DVT or any tenderness, any cellulitis on the calf. We write impression, and based on the impression, we suggest which investigations we are going to do. If the patient is coming with diarrhea, so we have to do stool specimen, we have to do bloods, including. Okay, so we do all these things, and then this is the discharge has been identified when I was doing my dissertation. So I have identified all these things which need to be taken care when we discharge patient. After doing all these things, we when we have all the blood results, everything available, we discuss with on-call consultant or SPR, and if there is any need, they will come and see the patient. If they are agree with the plan, we can discharge the patient with the take-home medication and we book them for follow-up. So toxicity of treatment, there are different type of treatments. We give chemotherapy, radiotherapy, immunotherapy, but I have written some side effects of chemotherapy and immunotherapy and cancer related. So chemotherapy is related mainly is the neutropenic sepsis, hypersensitivity reaction. They can have an anaphylaxis as well. So all the nurses are trained how to look after this patient, nausea, vomiting, mucositis. Uh, Immunotherapy is relatively a new treatment for cancer patients. So we are more and more seeing these patients with the side effect like colitis. They come with diarrhea. We send them a scan. We do all the uh, checkups and they come up as and then for cancer related as pericardial infusion, supravena cava, ascites, cerebral metastasis, hypercalcemia, these all are cancer related. When we review patients in AOS, we mainly see all these patients. Those patients who are unconscious, bedridden, with chest pain, bleeding, seizure, we don't see these patients in AOS. In a normal day, we see 6 to 8 patients, and hardly 1 or 2 patients get admitted or get transferred home. The referral we receive from telephone triage, outpatient clinic, radiotherapy from the specialist nurses, from the consultants and chemotherapy unit. The staffing in AOS, one nurse is allocated to triage phone and the rest of the staff is working in unit, advanced clinical practitioner, nurse practitioner, CS care worker, SPR. They are not in the unit, but they are around if we need a consultant, and SPR, they are around if we need to talk to them. Okay, so before we recruit anybody in acute oncology, they need to have a degree, chemotherapy course, cancer care course, communication skills. They should have experience working in acutely unwell setting, and the knowledge they should be able to look after patients, the PIC port, knowledge about different tumor sites, option of treatment and MDT roles, knowledge of the local and national policies, uh, communication skills to take triage calls and LS providers. Competencies for advanced practice, there are 4 pillars which has been identified by the healthcare education, by the England healthcare education system. So which is clinical practice, knowledge, skill, education, management, leadership skill, and the research. So to develop this role, role, ACP need to work with the supervisor. There is one identified supervisor which work with the ACP, and then they go through the patient, they go through the assessments, and then they signed off. And they also attend presentations, MDTs. They work with pharmacies, clinical nurse specialists. They spend time with different non-medical prescribers, so they can have different skills. They can learn different skills from different people. To adhere to our code of conduct, we use NMC guidelines, NICE guidelines, UCONS, ISMO, our trust policy and procedure, cancer center policies, and unit-specific SOPs. So as a ACP, I have to accept appropriate referrals in AOS. We need to have communication and consultation skills, timely documentation, working with other colleagues, maintain ethical approach and fitness to practice. Information gathering we do by talking to the patient, talking to their family members, clinical examination, and other procedures. Independent prescribing and pharmacology is also a mandatory for those who are going on ACP pathway, so they can prescribe when it is needed. ACPs are expected to interpret blood results, CT scan results, and make diagnosis. Discuss with the on-call team, admit and discharge patient, arrange take-home medication, and the follow-up appointment. And in the teaching, the ACP is supposed to train junior nurses and take in triage calls. ACP is also responsible for signing off nurses for those who are using PGD for the neutropenic sepsis. So PGD is the patient group directives. It is a pre-written medication which can be used if there is a need. So for neutropenic sepsis is the first line treatment of tazocin and meropenem, which we use as PGD, and I sign nurses off so they can use when they see unwell patient to suspect neutropenic sepsis. And we also collect door-to-needle data, which is a national agenda that those patients who are suspected neutropenic should have treatment antibiotic within an hour of arrival. So we collect data on it. We also educate those who are coming from other hospital to get exposure and cancer center like F1 and SHO. So they shadow us and they learn about acute oncology service and how we triage patient and what are the protocols we are using. And we also attend webinars and seminars to keep our knowledge and skills up to date. In leadership skills, I am a BLEEP holder. During the day, I hold as a ALS provider, and at night, I'm bronze on call. After every 6 weeks, for a week, I'm bronze on call to look after if they need any help and support in the ward, those nurses who are working the ward, so I can support them on the phone. And if they need any management related help, I can support them as well. I also attend senior nurses meeting, mortality meetings. So we are still collecting data on those patients who die within 30 days of their treatment, because it goes to the national data and has to be answered that what happened, because so many and like protocols has been set for giving chemotherapy, like patient need to have consultation, they need to be seen before treatment with the bloods, and still if anything happens, then there's a investigation about it. And we also have clinical governance meeting every monthly. Research and development, I have developed this performer. I have reviewed the toxicity assessment guide with the national team, which has been approved in 2023, and it is available online, which everybody can access, and it is very helpful. And we also training head and neck nurses. After my dissertation, it has been identified there is lacking in knowledge and experience of nurses about head and neck cancer patients. So we are working on it. And we are also developing an emergency box for the tracheostomy patient, those who come on site. So nurses don't run for their things and they have everything in one box. And we are working on developing, standardizing acute oncology teaching. We have just completed our pilot. Tomorrow, 22nd is the last date for submitting the performer, those who are taking part in the pilot, and then we'll have results, and then we'll move forward from there. Okay, so I'm going to discuss briefly about neutropenic sepsis. Neutropenic sepsis is one of the side effects of chemotherapy, and which chemotherapy can effect on the bone marrow and can suppress bone marrow, which is responsible for making blood cells. So when the blood cells are low, patients are very prone to get any type of infection. So if they feel unwell after having chemotherapy, it has been identified that 7 to 14 days is the time when they are really low. So if they're unwell, they have fever, they need to be seen urgently. and they are the priority patients for us. So we can review them, and we can give them antibiotic, and we can do bloods, and we maintain door to needle policy. And we have PGD in place, which we use to give. If not, nobody is there to prescribe, any the nurses who have been signed off, they can give antibiotic without prescription. The other thing which is very important for AOS is the spinal cord compression. So for spinal cord compression, Cancer Center is the hub where we receive all the referrals. So if the patient had MRI of spine at a DGH hospital and the doctors call, we advise them what are the process they should be following. So we have nice guidelines. We suggest that patients should be on high dose of steroids with PPI cover, and we suggest them to arrange whole spine MRI. And if they have like mobility issue, they should be on bed rest to prevent any further damage. And if the MRI shows MSCC, they need to be referred to neurosurgeon, who will advise if the patient is fit to have surgery. If not, then patient will be sent to Mount Vernon for radiotherapy and supportive care. The challenges we are having are very unpredictable workload, shortage of oncology trained staff, delay in getting results of the bloods and scan. We have very limited space. We have only 4 rooms to review this patient, and sometimes it's overwhelming to the patient can just walk in because they know we are there. So without calling us, sometimes they appear when we don't have space. So these type of challenging we are facing. Limited pharmacy timing, limited beds, inpatient beds, and lack of acute facilities on site. These all are the limitations we have. Thank you very much. Can have questions. If you have any questions, please.
Thank you so much, Riaz. This was a very informative presentation.
Okay, I think so our speaker is facing some kind of technical issues. So meanwhile, she gets back. I think so the presentation was quite insightful, and I hope that whoever is attending the session must realize that the importance of the oncology care nurses, their role, critical role in triage, especially I was very much impressed when Riaz was talking about the UCONs, which is the tool which is used for the triage. So I think so these are some of the pointers for the people who would like to opt their pathway as an oncology nurse in the future. And I think so Riaz very well talk about the competencies and the requirements to become an oncology nurse. So we are hoping that soon at AKU, when we will have a specialty track for oncology nurses, many of us will join and will follow this path.
I would like to tell all the participants that your joining is encouragement for us. रियाज ने जो 2 इम्पोर्टेंट चीजें आज उन्होंने हमें बताई हैं कि वहां पे जो ऑन कॉल नर्सेज हैं वो जो 24 आवर्स ऑन कॉल नर्सेज हैं वो अपने हाथ में ब्लिप सिस्टम रखती हैं जो पाकिस्तान में नहीं है तो ब्लिप सिस्टम का
yeah. So during the day we have a bleep. So anybody from hospital or from outside hospital can bleep us for any help and advice. Like GP, they can call us. The district hospital, if they're struggling with anything, can call us. If they have MSCC patient and they need any help and advice, they can call us. And during the night, we have a telephone because we are at home. So maybe that bleep will not work, but we are on call with the mobile. So the mobile number is with the hospital operators, and anybody want to contact us, they go through the switchboard and they ask for on-call manager, and they talk to us for any help and advice.
Okay, that's very good. अच्छा रियाज, फ्रैंक नर्सेस का जो रोल है एक्चुअल क्लिनिक में, आपने
जी।
बताया कॉम्पिटेंसेस का, सो व्हाट इज एग्जैक्ट रोल ऑफ द नर्स? कौन सी क्लिनिक नर्सेस रन कर सकती हैं, या वो क्लिनिक भी मल्टी डिसिप्लिनरी है कि नर्सेस वाइटल साइंस या असेसमेंट कर लेती हैं फिर कोई और चेक करता है? हाउ इंडिपेंडेंट नर्सेस आर?
नर्सेस के यहाँ पे डिफरेंट लेवल्स हैं, डिफरेंट बैंडिंग है।
जी जी,
Like,
हाँ, वो बैंडिंग की जरा बात करेंगे आप, बैंड्स कौन से?
हाँ, तो जैसे नर्सेस जब ग्रेजुएट होती हैं तो वो बैंड 5 होती हैं।
ओके,
ठीक है, सो बैंड 5 नर्सेस जो होती हैं वो हमारे पास एक्यूट ऑन्कोलॉजी में नहीं है, बिकॉज वी नीड हायर लेवल।
ओके,
तो बैंड 5 नर्सेस जो है वो वार्ड में काम करती हैं, to gain experience, to learn about medications, about patient care, to make nursing care plannings, all these things. So learn करती हैं management skills, nursing skills, and then they go for further courses. Chemotherapy course is mandatory when they are looking after oncology patient, those who are on chemotherapy. Cancer care course है, तो ये सारे courses जो हैं they have to attend and pass. जब वो बैंड 5 पे ये सब कोर्सेज कर लेते हैं और उनके पास 3-4 years का एक्सपीरियंस हो जाता है, then they can move to band 6. बैंड 6 में उनके पास थोड़ी और रिस्पॉन्सिबिलिटी आ जाती है. They can be in charge nurses in the unit, you know, they can teach junior nurses. For that they have to do a mentorship course to mentor students who come from the university to learn about nursing. So nursing students को mentor करते हैं,
जी जी जी,
and then they grow further and they do further they take further qualifications, and then they can be specialized nurses. Different tumor specific specialized nurses हैं, breast nurse है, lung cancer nurse है, colon cancer nurse है. So that those are जो यहाँ पे learning process में होते हैं, they call trainee CNSs. So they are band 6, and then they can groom themselves and go to band 7. So qualified specialist nurse जो होती है band 7 पे होती है, and they can run clinics like side by side with the consultant. Like when I was a breast clinical nurse specialist, I was doing wound clinic, I was doing like telephone clinic. If the patient is concerned about anything, we have a navigator system at Imperial where the patient call, and then the navigator book them in the clinic. If the patient is calling, breast patient is calling, prostate patient is calling, lung patient, so they book with different CNSs who is responsible for patient. So I was doing that clinic, and I was also doing end of treatment clinic where we can reassure patient is okay, they have their jobs, they are not struggling with psychological issues or financial issues and all these things. And we are still point of contact for them. They are discharged from the consultant side, but we are still there for them. So if they any point, if they need any help and support, they can call us, and we can bring them to see in the clinic and see them, or we can advise them over the phone, and we can refer them to other services. So we have so many things available for psychological support. There's Macmillan, they are doing a lot of things for like doing mindfulness courses for them, doing yoga classes, and doing massage and beauty therapy, all this for, because breast cancer patients are very young and they do get a lot of psychological issues. So we have all these services. Lymphedema clinic is available for them as well. Okay, we have wig service. So if anybody lose their hair and they like to have a wig, we provide them. If somebody doesn't want to go for doesn't want to go for wide local excision, and they have mastectomy and doesn't want to have reconstruction because of any reason, we have support available to provide them with prostheses and special bras. All these things is available for them.
So
So
basically,
after
nurses.
working on,
Yeah, please go
sorry,
ahead. Please go ahead.
yeah, yeah. So the specialist nurses, when they are like groom themselves further and they go for further studies, masters, and then they can be ACP. Like for ACP can do autonomous service, that they can do clinics, they can review patient, and they can prescribe medication for them. So at the moment, there are different specialties they are going on ACP pathway. They can be like pharmacists, they can be nurses, they can be like people from A&E. They were called before ANPs, but now it is changed to ACP because it is more autonomous, and they are reviewing the courses in the university to make it more usable for if the nurses finish their course, they should be fully ready to take their roles. So some people, they do it in their own leisure time. They fund themselves and they do part-time or full-time based on their own circumstances. Some, they do get sponsorship from the employer, like NHS provides sponsorship, and they work in the unit and they support the clinic to develop, and they also go to university once a week to attend their courses, and they spend time with the consultants. So when they are under like NHS, they're on sponsorship, then hospital supports to do all
So
these things.
Riaz, that means nurses have very powerful role. Different kind of nurse-led clinics are on,
Yes.
depending on the level of specialty. So
Yeah.
autonomous care provider nurse are running full scope of practice in the nurse-led clinic, right?
Yes.
And
Yeah.
we have, Riaz, it was very good. We have long way to go. आई थिंक कि आज जितनी नर्सेज ने ये आपका सेशन सुना होगा, और आप जब भी पाकिस्तान आती हैं तो हमें जरूर बताइए,
Inshallah.
क्योंकि हमें यहाँ पे पायलट करना चाहिए, स्पेशली जो एजुकेशन सिस्टम और बैंड सिस्टम है, और स्पेशली कॉम्पिटेंसीज को मेंटेन करने के लिए भी आपका लाइसेंस जो होगा वो स्पेशलाइज्ड लाइसेंस होगा, बियॉन्ड
Yeah.
योर नर्सिंग लाइसेंस, ठीक है ना?
Yeah.
तो उस लाइसेंस को भी किसी वक्त हम बैठ के आप लोगों से लर्न करेंगे कि जब आपका बैंड चेंज होता है या एवरी ईयर या एवरी 2 ईयर, जो वो लाइसेंस को मेंटेन करने के लिए मेंटेनेंस पॉलिसीज क्या होती हैं नर्स के लिए, ऑटोनोमस केयर प्रोवाइडर की क्या है, या बैंड 6 में क्या है, बैंड 7 में क्या है, ये बहुत इम्पोर्टेंट है। क्योंकि हम अपने आप को सिर्फ ऐसे ही मास्टर्स की डिग्री या उस पर स्पेशलिस्ट नहीं कह सकते हैं, राइट? जब तक के साथ साथ में एक्सपीरियंस हो, हमने वो सारे एक्सपीरियंसेस, ईयर्स और प्रॉपर एक्सपीरियंस क्रॉस किए हो, फिर ही कोई ब्रेस्ट कैंसर स्पेशलिस्ट, कोई लंग कैंसर स्पेशलिस्ट नर्स, कोई ट्यूमर स्पेशलिस्ट, राइट रियाज? सो दिस वाज वेरी वेरी इंपॉर्टेंट। व्हाट वी विल डू, हम अपने पार्टिसिपेंट्स का फीडबैक भी लेंगे और आपसे इंशाल्लाह हम दोबारा बात करेंगे, और हमें बहुत ज्यादा जरूरत है नर्स लेड क्लिनिक को पाकिस्तान में पायलट करने की। तो हम देखते हैं कि ग्राउंड कहाँ पे तैयार होता है, और इंशाल्लाह हम इस तरह करके और आपको जरूर आपसे कांटेक्ट करेंगे। We are very, very happy that Aga Khan University alumni, and one of the alumni is Riaz. She offered her services and we requested her to do webinar today for us, especially in nurse-led clinic. And today it was the first time we are hearing for nurse-led clinic. And inshallah, the more time will come, we will hear more about the nurse-led clinics and how powerfully nurses are running their clinics and their practices. और रियाज ने जो परफॉर्मा का बताया वो सब practice-led चीजें हैं. तो practice ही good researches लाती हैं और practice ही हैं जो education को change करती हैं और current education में रखती हैं. Thank you so much to everyone. Thank you so much to Riaz. Riaz, we will
Thank
be
you.
in touch with
My
you.
pleasure.
Thanks a lot.
Thank you.
Thank you. Thanks a lot.